We're a bit over, but I think we have time for a few questions. If anyone have any questions, I believe there's a mic.
Thanks so much. That was really interesting. I think I have to review those slides. I remember them as well. But I left the A2 line. I remember that. My question may seem a little odd because I'm trying to understand about women when they're pregnant are constantly getting exposed. And my question is, are there antibodies that are circulating that an infant has and is it only there for a few months? So that infant's about to receive, let's say, an ABO incompatible transplant, do they trigger something if they're on the first pregnancy, but maybe like the second or third? Like, is there something that may happen as they're carrying the mother's maternal antibodies that she might have carried with the current pregnancy, but also former pregnancy? And is there something that's triggering to an infant that potentially could impact ABO? I was just wondering, given that the mother's at risk also for ABO antibodies.
So just to repeat the question, it was an excellent question about mothers are going to be often exposed to non-self ABO in pregnancy, and is there also kind of a memory component to that? I'm sort of paraphrasing what you're saying. So we do see passively acquired ABO antibodies in infants, and we actually did see that in some of the samples that we were looking at, in samples from the cardiac cath lab and other stored HLA antibody or HLA specimens. They don't seem to cause harm. ABO, so unlike RH hemolytic disease of the newborn, we see very little ABO hemolytic disease of the newborn, although it is rarely observed. And one of the reasons we think that happens is the branching of the A and B sugars looks different in fetal red cells and then as compared to older red cells. So perhaps the antibodies don't quite see their target because otherwise you would expect them to cause massive problems in the children, and they do not. So that could be why. And if they're IgG though, IgM antibodies are very unlikely to be present in infants passively acquired from mom. So the IgG antibodies, it will depend on what method your blood bank is using to detect them. And at least at our center, they're using a room temperature non-antihuman globulin enhanced, so they're unlikely to cause a false positive. But they could if the transfusion medicine laboratory is using an IgG enhanced detection method. And so we see the same thing in HLA antibody analysis. Actually, we'll see in a one-day-old infant, if we see HLA antibodies, they're from mom, right? And so then we'll have to work around that as well. Sometimes we'll get samples from mom, test to confirm oh, that's where this is coming from. And if an infant, the anti-A or anti-B antibodies don't match the expected antibodies of the phenotype of the infant, that also suggests that they're passively acquired. Also, even from transfusion, they can be passively acquired. If your infant who's a blood group A receives an O-irradiated red cell unit, they're going to get passive antibody that way as well. And then as far as memory, we have been using a little bit of there's a memory assay that uses a polyclonal stimulation of circulating of cells collected from peripheral blood. And we do see IgG antibodies in the supernatants of those. We don't really understand what that means yet, but I think that's something to be explored further to see if pregnancy is a disadvantage, previous pregnancy with a mismatched ABO, if women are disadvantaged in transplantation. But we did do a largish study in people receiving ABO A2 incompatible transplants, and we actually did not see differences, male-female differences in that study, suggesting that perhaps it is not induced by pregnancy. But I think that's an excellent question. Still needs further studies. Did you want to add anything?
Thanks again. I was just wondering what's going on at the level of tissue, like this tolerance is really intriguing. So you've got all these multiple different glycans, and you've made antibodies to those glycans. I assume you look at the protein over time and seeing which ones come and go. And are they all separate genes? So they've got separate mRNAs, they're regulated in a different manner? Like what happens over time to each of these glycans within tissue? Are they expressed constantly? Like it's sort of constant. The constant is I think that they're just there.
Yeah, well,
it's just not there.
It hasn't really been studied much. I mean, the immunohistochemistry that I showed you was, I mean, that's the first time that we've had monoclonal antibodies because we made them to actually look at the glycans in the different tissues. It hasn't really been studied very well. And as both Anne and I said, we haven't, the next step is to link it to the zygosity as we study the genotyping, and we can link the zygosity to the levels of tissue expression over time, because at the moment we haven't had the tools, nobody's done that yet.
One time.
We haven't done longitudinal studies of the glycans themselves. That's kind of hard to do unless we are able to work with, for example, transplant programs that do routine biopsies and actually look at the same individual's tissues over time. Is perhaps some way we could get at that, but it's hard to actually find those tissues to study over time. Did you want to say something?
Yeah, no, I mean, actually, it's a brilliant idea and really interesting question, because we have those patients who 20 years down the road still have no antibodies against their A and B. And that's actually an interesting parallel with people who are like children that wear pneumococcus on their tonsils. They get vaccinated, they develop antibodies against every other phenotype, just not the one that they're carrying. We stopped doing biopsies at 3 years. So we don't do routine biopsies after that because the yield is so low that we will find surprising rejection. And so we wouldn't have long-term, but for the first 3 years, we could actually look at, what happened on those biopsies. Interesting idea.
And actually, I think one interesting way that could be done is a use of something like nanostring, where you can use formaldehyde fixed tissue, but add to that, customize it to look at the glycosyltransferase expression and see if there's changes in that way, which isn't part of any standard panel. But I think that would maybe, if I understand your question, that would maybe get through that. But maybe we'd also have to think about the H glycans, fucosyltransferases, and other things as well. Because if the H isn't there, there's nothing for the A and B to decorate on top of. So it might need to be, you have to think it through and make sure you're including all of that. And then also make sure that it's aligned with, if there's genotype differences, whatever you're using as your molecular way of studying that you're using it for the right typing of your donor.
Nobel Prize 2022. That's what it was.
Great. Well, thank you so much, everybody. And thank you so much for our speakers.